I'm sorry. Is this one? No, silicone oil toxicity, I'm sorry.
Mr. Chairman, ladies and gentlemen, I'd like to thank the organizers for the invitation to share my ideas about silicone oil toxicity. I have no financial disclosures or other conflicts of interest. Already in the era of external retinal detachment surgery, silicone oil was used in vitreoretinal surgery. First, Sibbes and Scott described the use of the injection of silicone oil as an intraocular tamponade in complicated cases. And after the introduction of the pars plana vitrectomy in the 70s, Sivanovic and Mertens started to use silicone oil as a temporary tamponade after the removal of the vitreous. In the 90s, the silicone study group demonstrated that silicone oil and long-acting gas were equally effective in patients with PVR. But in 2004, Leeuwen was the first to publish on an unexplained visual loss after removal of silicone oil. And since then, many more cases have been described. Typically, a patient with a macula on retinal detachment and a normal vision receives a silicone oil tamponade, often because of a giant retinal tear. And then immediately following uncomplicated oil removal, the patient experiences a dramatic drop in visual acuity. Extensive workup does not reveal any structural abnormalities, as you can see in this OCT image. In 2006, Herbert showed that the visual loss is associated with a small, deep central scotoma, as demonstrated in this Goldman parametry. And 6 years later, Christensen and Lacour observed that in patients with unexplained visual loss, the inner retina was significantly thinner compared to similar patients with gas tamponade. So to summarize the characteristics of silicone oil-related visual loss, visual acuity is low, often between or around 0.1, and it does hardly recover. Sometimes patients complain of a change in color perception. The onset of visual loss may be during the tamponade or immediately following oil removal. No structural abnormalities are detected, in particular no macular edema, no epiretinal membrane, or macular atrophy. There's a deep central scotoma, and later on, the inner retinal layers become thinner. An important question is, how often does this complication occur? Is it a rare incident? Is it limited to certain clinics or certain types of oil? In the past 5 years, a number of studies have tried to answer this question. And these are all retrospective studies with some differences in case finding and follow-up. Still, these are the only studies that have systematically looked into this issue. I've tried to summarize the results. As you can see, there is important differences in the population at risk. Some studies started off with macula on detachment patient and compared gas to oil tamponade, while others selected all silicone oil removal procedures with no distinction between the macula on and the macula off detachment. This study from the Moorfields Eye Hospital did both. Of all patients with a silicone oil removal surgery, 3.3% was noticed to have a severe and unexplained visual loss. However, when they selected patient with a giant retinal tear and an attached macula, the percentage of unexplained visual loss rose to 50%. So when you only look at the macula-on population, the incidence is pretty high, ranging from 20 to 50%. In these studies, no consistent risk factors were found. In particular, eye lamp peeling, perfluorocarbon acid use, there was no association. In our series, there was a statistically significant association with the duration of the tamponade. In this figure, I have plotted the mean duration of the oil tamponade in 8 case series. And as you can see, all cases had at least 3 months, but most had 4 months of tamponade. What are the possible mechanisms of this phenomenon? Some have suggested that it is an optic neuropathy, either caused by ischemia or by direct infiltration of silicone oil droplets. And there are some reports on oil vacuoles in the optic nerve in enucleated eyes, but it was after many, many years of tamponade. And it's unlikely, I think, that this can explain these cases of after a couple of months. But more importantly, electrophysiological studies point towards a macular dysfunction and not a primary optic neuropathy. Tom Williamson has shown in a computer model that foveal light exposure may transiently increase during the oil removal procedure, up to phototoxic levels. This is an interesting hypothesis, but it cannot explain visual loss during the tamponade. Many authors refer to the paper of Winter on potassium accumulation as a cause of silicone oil-related visual loss. He suggested that the normal buffering of intraretinal potassium by the vitreous is disturbed by the oil tamponade. We have tested this hypothesis by measuring potassium in retro oil fluid, but could not detect a difference in mean concentration between retro oil fluid and normal vitreous. Another very interesting hypothesis is the macular pigment, which may dissolve in the oil, depriving the macula. How this would lead to a sudden visual loss is, however, speculative. But perhaps we are misled by the fact that the macula was detached without anyone noticing. In our case series, we used microperimetry to demonstrate the deep central scotoma, as seen in this figure. This is a patient with a silicone oil-related visual loss. Visual is an 0.1 macula on, detachment with silicone oil. And what you can see, there is a central scotoma in red. And how about a patient with a macula off detachment? Here you see microperimetry in such a patient, same low visual acuity, macula off and gas. There is somewhat lower sensitivity, but there's no deep central scotoma. So, macular detachment is not the explanation for a central scotoma, and also microperimetry is able to discriminate between visual loss due to the macular detachment or to the oil-related visual loss. We decided to use this technique to study the effect of silicone oil on visual acuity and retinal sensitivity by comparing 4 different groups, macula on and macula off, with either gas or oil tamponade. And we included 10 patients in each group. In this figure, the visual acuity, expressed in logmar, is shown after the tamponade for macula on patient and macula off. As you can see, vision is good after macula on and gas tamponade. The same group of patients with silicone oil tamponade had a somewhat lower visual acuity. By the mean was the same, but there were some outliers. Interesting, about 30%, remarkably similar to the incidence studies. And how about the macula off? As expected, visual acuity was somewhat lower compared to the macula on, and it was even worse after silicone oil, but it was not statistically significant. This is the same figure with the results of the microperimetry. On the y-axis is the central sensitivity plotted, and around 16 decibel is normal. As expected, these normal values are found in a macula on patient with gas tamponade. in patients with a macula on and oil tamponade, the mean retinal sensitivity is lower, statistically significant, with a wide range. Some of the patients also had a low visual acuity, qualifying for the diagnosis of silicone oil-related visual loss. But there are more patients with a scotoma. Interestingly, the same holds for the macula off patients. Retinal sensitivity is somewhat decreased compared to macula on, but more severely in combination with the silicone oil tamponade. And this was a statistically significant difference. These are some examples of microperimetry. This is a patient with a macula on detachment and a gas tamponade, normal sensitivity. Vision is 0.8. And these are two patients with the silicone oil-related visual loss after macula on. You see in red the very low central sensitivity. This patient has a visual acuity of 0.3 after macula off detachment. And these two patients had a rather similar visual acuity, 0.4, 0.2, but with a severe central scotoma. These results suggest that silicone oil-related visual loss may also occur after macula off detachment. And why not? Why would the potential toxic effect of silicone oil be limited to an attached macula on presentation? Visual loss in these patients will be attributed to the macular detachment. However, since we do not perform microperimetry in these patients, the actual cause of visual loss may go unnoticed. Of course, there are limitations to this study. The numbers are low. This is due to the low frequency of silicone oil tamponade, particularly in patients with a macula on detachment. But more importantly, there will be some confounding by indication, meaning that other factors associated with the use of silicone oil may explain our findings. For instance, factors associated with PVR. But how these factors cause visual loss is unknown. A randomized controlled trial would solve this issue, but in my opinion, it's not ethical to randomize between gas and oil in severe cases of PVR, where a surgeon would choose oil for a reason. Interestingly, there is supporting evidence from two recent studies on retinal thickness. In eyes with macula off retinal detachment and oil tamponade, the inner retinal layers were significantly thinner compared with gas and control patients, particularly in the nasal quadrant. So, not only in patients with silicone oil-related visual loss, but in all patients with silicone oil, there may be some retinal thinning. In conclusion, silicone oil-related visual loss is a severe complication of oil tamponade in macula on retinal detachment patients with an incidence of around 30%. Central scotomata after silicone oil may occur in macula on as well as macula off retinal detachment patients. Our results suggest that silicone oil should be used cautiously and be removed as soon as possible. But further research is definitely needed. I'd like to thank my colleagues and thank you for your attention.
Thank you for that very, very nice talk and review of the available literature. Well, it looks like it's the eyes that have got good visual potential in which we have to worry, isn't it?
Yes. Then the visual loss is, of course, most obvious. But even in cases with the macula off, well, you don't know what would be the visual acuity without any effect of silicone oil.
Yeah, absolutely. But,
and the central scotoma may occur apart from a good visual acuity.
Yes. Has it changed your approach to cases? Are you using silicone oil less?
Yes, definitely. We try to be as reluctant as possible and keep the oil in for not more than 3 months. That's, in our opinion, a maximum.